outcomes it has. Now let us go to something which is uniquely Indian. Can I have my slides, please? Dr. Kirti Singh, aage beta, I have it. Mil gaya. Thank you. Yeah. So something which is, we talk about angle closure glaucoma now more importantly. So the topic given to me was the lens and iris parameters in ACG management and how do they define. So glaucoma, we know in Asia, more than 3/4 of the angle closure population is in Asia, and in India we are sitting at a volcano of angle closure glaucoma. Study from our center, angle closure glaucoma comprises 50% of the glaucomas, and many of them come to us with blindness. And the dependency on escort is there, self-earning, obviously Ayushman is coming in, but there's poor access to healthcare. So all these facts and the fact that lens vault is invariably high, which worsens the angle clouded in predisposed eyes, which we found that in angle closure it was almost more than 2 times. Like this is the lens vault in angle, open angle was 0.36, whereas at angle closure it was 1.06. So we really did find that exaggerated lens vault or the volcano configuration as it is described, which is more than 1/3 of the distance between corneal endothelium and the scleral spur line, is an independent risk factor for angle closure glaucoma. The other fact of iris, which is established since our post-graduation, we've been reading about the sphincteric atrophy, the whirling, the ectropia on UVA. We know all that the iris close and angle closure glaucoma are many. What we now need to know is, in addition to that, we have something called a thick peripheral iris roll, or the PIR, which is a problematic situation, and in those situations the treatment will vary. When we went back to literature, we found that Quigley had long ago said that iris is a sponge, which is a cause of angle closure, and this has now come up more after the imaging devices has come in. Now, all these iris parameters of curve, area, thickness have been independently associated with narrow angles after adjusting for age, gender, and anterior chamber depth. However, there's a difference in opinion. Some studies from Asia have said that iris curve is more, and the gentleman sitting with Dr. Arun, studies from Singapore have said that iris curve is more, iris thickness is more. Yes, Arun? But the Indian studies from Dr. Sehota et al. Said that the iris thickness is less in ACG. So let's look at a few of these studies from the Singapore group of almost 1400 eye studies in different Chinese, Indians, and Malays. Said that lens vault of more than 667 was independently associated with narrow angle. However, from the same center, when they did only Chinese studies on only in Chinese patients, they said again the lens vault was significantly higher, but the angle closure odds ratio was much higher, and lens thickness was not associated with angle closure glaucoma. A group from South Korea on Asian eyes talked about the relative lens vault, which had the highest Auro curve. So they recommend that building up of the normative database as a screening tool in predicting the potential risk of angle closure is important. Increased iris curvature, less iris thickness was the study from Iran, and where they said the steeper iris was independent factor which predicts the angle widening post LPI. So things have been evolving since our times when we had read that steeper iris, more curved, okay, angle closure. And this, the thing which I was talking about, the study was about thick peripheral iris roll, which has a prominent circumferential folds. In that case, in addition to plateau iris, in this situation also the PI would be ineffective. And we all know about the Eagle study where the exaggerated lens vault obviously is a predictive of angle closure, so there's a role of lens extraction. So what have we understood from all these studies till now? That there's an ethnic variation, which was again clarified by the study from the Spain group. So coming from all these studies, we came to the Indian study. Let's talk about the lens parameters and iris parameters specifically. So we studied group of 81 eyes who required cataract and combined surgery for angle closure glaucomas vis-a-vis age-matched open-angle glaucoma eyes, and we found that lens vault was significantly more in the angle closure glaucoma eyes, and the lens thickness was similar in both the eyes, and the relative lens vault was also very much different. So this was like echoing the previous studies where lens vault and relative lens vault and not lens thickness was significantly increased in angle closure glaucomas. Few of the case vignettes we can show you. This is the lens vault in angle closure glaucoma, and you can see the lens vault in POAG. So it is very obvious now when you start looking for it. And when you start looking for it again, if you go back on the slit lamp, you will find that this is a volcano configuration. So once you had imaged them, you started looking for them. Iris thickness, again we found that the iris curve and iris area was surprisingly in our patients decreased, which was not expected. We'll come back to that later. So lens patometers we also studied in angle closure vis-a-vis just plain operable age-matched cataract patients. And no surprise here, we did find that the lens thickness was more and the lens vault was significantly more and the relative lens vault. So similar findings in compared to cataract alone, compared to the age-matched cataract. These are a few of the case vignettes of the PSCGI and the age-matched plain cataract eyes. But in the iris pyrometers, the iris curve, why was it less? We went back to our data and we found that maybe it is less because the PI was done for all these patients, and post-cataract surgery, there is a flattening of the iris curvature which is contributing. So it's dynamic. It's just not that it is a simple, the iris curve is more. Once you do a PI, things do change. So we found, like the other study, that we had a thinner iris at 750 microns and 2000 microns, and this was reduced, both of them were reduced post cataract surgery. So going back, in Asia itself, if you are looking at Chinese and Malays, you are finding that the iris curve and the iris thickness is more. If you are looking at Indian eyes, the iris thickness is less. And how does it matter to all these matter? Because the surgical outcomes are different. Like you can see now, this is a volcano configuration, and the capsular rhexis in a ACG patient is a different ball game vis-a-vis in an open angle glaucoma patient. And this is a very high lens vault, almost 0.9. Till now we've done up to 1.5. And you can see it is, and this we don't have Helon, so this is more difficult. Other thing we found that the iris behaves differently. There's a floppy iris-like thing which is seen in tamsulosin, and it keeps coming out during surgery. So sometimes you have to do a small surgical PI to prevent this constant billowing of the iris. And in addition, for failing filters in angle closure glaucoma, when we do cataract surgery, we also do an intra-op needling with an ab interno revision, like I'll just. So once the suture is placed, this filter was there, in which we are doing now a ab externo needlings to revive the bleb, because post-surgery the blebs do fail. Another thing which we noticed in our patients was that the iris bleed was more common in angle closure glaucoma, just like the Amsler sign in Fuchs. This was we've been finding this in glaucoma and angle closure glaucoma patients. So to conclude, how is the surgical outcome redefined after finding all these iris signs and the lens signs? We correlated our IOP control post phaco or phaco trap with the iris and the lens. What we found as that just in angle closure glaucoma with phaco alone, it could reduce the IOP over 4 months by 6.7 millimeters of mercury, and even the the requirement for medicines reduced. And it was related positively to the iris curve and negatively related to the iris thickness at 750. So what does that mean? That lens is bulkier in ACG. We know that. That's a no-brainer now. Relative lens vault is a more sensitive marker related to angle closure. Iris parameters after phacoemulsification, not only do the iris curve reduces, but the iris thickness also reduces. The steep iris configuration from 37% pre-op reduced to 13%, and as expected, there was a significant reduction in the ITC index in the ACG cases. The predictions of IOP control was there was a positive correlation with the pre-op eye curve. More the eye curve, more steep the iris, more was the post-op reduction. Negative correlation with the iris thickness. Thicker the iris, lesser the post-op IOP reduction. and there was a positive correlation with the pre-op ITC index and lens vault both. So bulkier the lens, more the ITC index, more was the IOP reduction. So what do we end with? We have a large proportion of angle closure glaucoma patients in Asia. Relative lens fault needs to be looked at more, and this can predict the IOP control. We need to start looking at the volcano configuration and start planning lens correction along with the trabeculectomy. We need to generate normative lens vault databases, and iris is important not only in the anatomy, the physiology of iris is different. It's a culprit in angle closure glaucoma. We have a fat, bulky lens with a floppy, flaccid iris, which often bleeds. So both phenotype and the behavioral characteristics are different. So to conclude, even in these studies from Asia, from let's say China, Singapore, and India, are showing different ethnicity. Thank you.